welcome to the COVID Advocacy Exchange. I'm finding myself having to recompose after the chat we just had with all of our speakers today. I'm just so honored to welcome you into this conversation, and my cheeks are still hurting from all the smiles we're doing. This live session that you are a part of is our 9th episode in this program that we started all the way back in March. And I can remember when we first started putting this together, we knew that we had to act quickly. We knew that the issues that the global advocacy leaders are significant and severe. And I can remember the intensity of how do we get something moving so quickly, bring together so many people from so many different areas, and do something really meaningful together. As I've gotten to do these introductions each week, I'll be honest that each week has brought a different kind of emotional intensity for me, because each of these topics has been created together by the advocates and the individuals who are dealing with them in their countries. When we started this, we knew we wanted to invite advocacy leaders and people living with these conditions from around the world in different areas and who are dealing with all different topics. If I think back on our June 4th live session, it was focused on best practices for going virtual. And for all of the physical events that have been canceled because of COVID, if we just think about the impact to individuals and organizations, those physical gatherings are the lifeblood of global advocacy. They are how we share information. They are how we share inspiration. They are a huge part of fundraising for the global advocacy organizations. And I can remember preparing for that session, all of the things that I wanted to share. My team, our team with Grit, lives in this virtual space, not creating virtual meetings, but creating virtual experiences. Ben just said in our prep just now, just getting to see everybody's face and feel connected changes the way we're impacted through COVID. And it has been such an honor to be a part of these and to collaborate in the way we have. That session that I mentioned, the best practices for going virtual, there was so much that I was excited to share, so many things that we've learned, so many challenges we've identified. And I remember as that panel conversation started, I was just overwhelmed in a positive way with all the knowledge I wanted to share, and really how proud I felt to be a part of this. Preparing for today, I have a different overwhelming sense of emotion. Today's topic is healthcare policy and change. And it is focused on how we make the healthcare system something better because of COVID. These last few months around the world have in many ways been an awakening of some of the issues that we need to address in our healthcare systems. The disparities in how healthcare is delivered and received, the experiences and the outcomes are being profoundly spotlighted now around the world. And this topic today, this conversation that you're a part of, wherever you're dialing in from, has been put together by people who are doing really world-changing work. They are world-changing individuals. I have the deep honor in just a minute to introduce our moderator. Her work and her passion around the globe will inspire you the way it has inspired me. We have leaders from National Health Council organizations, from international advocacy organizations, and as always, the patient voice living this experience. These conversations are meant to bring together different voices, different experience, and different expertise. And your voice is a huge part of this conversation. I encourage you to use the chat function at the bottom of the screen. Please jump in, make comments, let us know where you are. In fact, if you want to say hello, just type in what part of the world you're joining us from now. Thank you. I'll be back at the end after this conversation to share some closing remarks and to tell you what's coming up. I'll also share a link at the end of the overall conference and the exhibitor area, so you can get a sense, provide a tutorial of all the different exhibitors and resources and the things that are coming up. I feel like before I introduce Esther, I'm struggling actually to try to wrap all the feelings that I have about this session into something that I can impart in what this means to me personally. And I think the only way I can do that, if I think about purpose, it is how much we all share a passion for increasing survival and improving quality of life. And we are all a part of that conversation. Everyone's voice, whether we are in industry or advocacy or individuals or some mix of all these roles, we are a part of this overall experience, and all of our voices matter. So please use yours. Please be a part of this, and please let us know what we can do to make this truly meaningful for you. I'd like to thank our partners who have brought this to life. This whole program is proudly supported by Bristol-Myers Squibb to support global advocacy and the issues we're facing. Our partner at the Evoke Kind team really cares about telling these stories, elevating our humanity as much as our health. And I also want to give a deep thank you to our team with Grit, who works around the clock with everybody to bring us together for these sessions. Thank you. Okay, Esther, it is my deep honor to introduce you to Ester Banque, who is the Senior Vice President of International Commercial for Bristol-Myers Squibb. You will get to hear not only the work that she does, but the personal passion and humanity that she brings to it. I'm honored to welcome, and please help me invite Ester Join to lead the conversation.
Thank you so much, Dave. Actually, the honor is mine to be joining this important session. We have an exceptional panel, which I'm going to introduce in a minute. But first of all, let me share a couple of things about my experience in healthcare. More than 25 years in healthcare. Internationally, both in the US, but also in many other countries around the world. And as you, Dave, has mentioned, I'm the Senior Vice President of Intercontinental countries for Bristol-Myers Squibb. And this is a region that spans over more than 60 countries across 5 continents. We're talking about Latin American countries, Central Eastern Europe, Middle East, Asia, Australia, Russia. So we have a very diverse view of the world and diverse view of the many healthcare systems and realities that our patients are facing across the world. But there is one constant. Patients struggle to get access to healthcare and innovation across the world as well. So with my team, we are very passionate. Every day when we come to work, we know that what we do matters and makes a difference and helps people that can have a better chance in life and better healthcare. And we really work hard to make that happen, to contribute from our perspective. You mentioned, David, that COVID has seriously impacted healthcare and access to care and medicines. And that's right. And I can see on my day-to-day how our teams are also witnessing and working on improving in our own capacity that patients get access to healthcare and to our medicines. I'm going to just provide very quickly a couple of examples. For example, in Brazil, the entire big part of the local distributor got sick with COVID. So my team had to work with the local distributor to find ways to make sure that there was no interruption in the supply of our medicines to patients. Or, for example, in the Middle East, because of the mobility restrictions, originally our medicines were only distributed in large cities, in hospitals in large cities. So we have to find ways, also working with the local government, on how to make our products also available in rural hospitals. Or in China, where because of COVID as well, the government supported e-commerce, which was unheard of in the past, where physicians could even prescribe online, which I think is one of the few countries, maybe the only country, that it can be done. And then my team had to react overnight also to make sure that we could adjust to that new reality and continue the supply of our medicines to patients. So, and just to cite a few, but I want to reassure you that everyone in our organization works with the same commitment and passion to help patients get access to medicines and innovation. COVID has also touched my personal life closely. My family is in Spain. I'm originally in Spain. And my mom and my sister got sick of COVID at the beginning of the pandemic in Spain. The difficulty here was that my mom didn't have high fever, but she was really feeling sick, and COVID was affecting her immune system, her cardiovascular function, and neurological function. But she wouldn't be accepted in a hospital because she didn't have high fever. So I can tell you that I had the worst month that I recall for a long time, calling her every day, checking on her, and making sure that she had everything she needed. My sister was helping her, but I've never felt so far away from home as that month, because my family, my dear family, was also in trouble and getting difficulties to get access to care. So COVID is hitting, unfortunately, many of us directly. So, and with that, I would like to introduce the exceptional panel that we have today with us. Our panel is going to introduce themselves more deeply, but allow me to at least name that we have Eleanor Perfetto, who is the Executive Vice President of Strategic Initiatives in the National Health Council. That we have Katie Jones, who is a cancer survivor and patient advocate. That we have Lily Cannon, who is Operations Manager in the Thalassemia International Federation. And Katie Rizvi, who is the co-founder and executive director of Young Cancer Europe. You'll see that what they do is really important to help get patients access to better healthcare. And they're also coming from different parts of the world, which also is very interesting to hear their views. So without further ado, I would like to ask Eleanor Perfetto to introduce herself.
Got caught muted. Sorry about that. Thank you so much, Esther. And I want to thank everyone for putting this together and for inviting me to be here, and to thank my fellow panelists. We've had some preliminary meetings to get our discussion going, and it's an honor to be with them on this call. I am from the National Health Council. The National Health Council is a not-for-profit in the US, and we are a membership organization, so everyone who is in our membership are organizations. We have 5 different categories, and the largest category of membership for us is the patient advocacy group category. And the membership spans from the largest groups that you could possibly think of in the US, like the American Heart Association or the American Diabetes Association, but also some smaller rare disease groups. So we run the gamut from very large all the way through small, representing over 160 million people in the United States with chronic diseases and disabilities. So if 160 million people have at least one chronic disease and disability, and they are well represented among our membership. And we do a tremendous amount of policy work in the US. And so during the time of COVID, that's been a main focus for us in thinking about policy, in thinking about what is needed by the patient groups themselves in order to survive the COVID pandemic and what they're going through, but also for the patient advocacy organizations, and also for the patients themselves that they represent and what they need. And I think we have to always keep in mind, Esther brought up the example from her family, and I also have an example in my family of how COVID has had an impact on people who actually have not contracted COVID. So for example, I have a brother who was diagnosed with cancer very early in the pandemic. He was scheduled for surgery, and his surgery was changed several times in order to avoid having to be in the hospital during that period. And he was discharged very early, almost too early, with not as much support as he should have had. So we have to keep in mind that in addition to those individuals like Esther's family who have been directly affected by COVID, we also have many people with chronic diseases and disabilities who have been affected also because their treatment is interrupted or their treatment is disrupted in some way. And so I think that these are important things to keep in mind as we go through these times. And I'm going to stop here and let the introductions go on that Esther's got planned.
Thank you, Eleanor. And thank you also for sharing your personal situation, family member with COVID. Well, can we have now Katie Jones, who is a cancer survivor and patient advocate? Would you like to introduce yourself, Katie?
Good afternoon, or whatever time I'm reaching you. I'm Katie Jones. I've spoke many a times for BMS at different locations, and I am a cancer survivor, originally diagnosed in 2002, terminally diagnosed in 2011, but as you can see, 2020, I'm still here. Thanks to a lot of speaking up and pairing with the right people, I guess, at the right time, I've had to basically take a lot of no's and turn them into yeses. I've had to argue my case in front of Congress. I have become a very squeaky wheel for somebody who's normally introverted and shy. But as you can see, I'm still here. I do appreciate the idea that I'm a participant in this because I'm actually able to see some of the fruits of me speaking up. And now it's kind of hard to shut me up. Thank you for having me.
Thank you so much, Katie. You have an incredible and inspiring story that we can wait to hear more deeply, and also your reflections on how you think COVID will have affected even more that difficult journey, because that's where many patients today, unfortunately, are finding themselves in. So if I could go now to Lily Cannon, who is the Operations Manager for Thalassemia International Federation. Would you like to introduce yourself, Lily?
Yes, thank you, Esther. It's great to be with everyone here. It's such an honor for a disease-specific organization to take part in such a discussion about reshaping policy after COVID. I think it's something that we all need to start thinking about. Just a little bit about myself. I joined the Global Thalassemia family 10 years ago. And it's been an honor and a privilege to advocate on their behalf across the world, specifically with the World Health Organization and the United Nations, to bring thalassemia treatment to be accessible across the world and to all our patients in the 62 countries where we are located. For those who do not know about thalassemia, it's a benign hereditary blood disease that requires lifelong transfusions. So I have a lot to talk about the issues concerning blood donation that have occurred during the COVID-19 pandemic. And yeah, what you were saying about your family being so far away, Esther, it really rings true for myself as well. I have family in the UK. I'm currently based in Cyprus, which is a small island of the Mediterranean. So there's a lot of concern with my elderly aunts and uncles that are in the UK, but also my husband's family is based in Greece. We're a very international family. So COVID-19 has really brought issues of distance and being away from your loved ones and impact on mental health to the forefront. So it's a pleasure to be with everyone here, and hopefully we'll touch on a lot of issues today.
Thank you so much, Lily, for sharing a soundbite of what you do. We're going to discuss this a little bit later. and also your personal situation. When we live internationally and away from our loved ones in these moments is where I think we realize how important they are. So thank you so much. And then finally, Katie Rizvi, who is the co-founder and executive director of our Youth Cancer Europe. Would you like please to introduce yourself a little bit more and please go ahead.
Thank you so much. And hello, everyone. It's a real pleasure to be here. And just listening to everyone's personal stories, it really is quite impressive how COVID has affected us on every level. I can relate to the story of a very international family and not being able to travel across borders. And this is something that the European Commission just released a paper about yesterday, on the 15th of July. There's a timeline for looking into how cross-border travel can be encouraged even during pandemics, so that it causes less inconvenience for personal mobility and for the transport of goods, such as medicines as well. And because I do represent Youth Cancer Europe, and our network is made up of young people under the age of 40 from 31 European countries, we have a tremendous insight into how this pandemic affected everyone. And we have some data coming in now that we would like to talk about maybe later from across the continent, about how people with chronic diseases and with cancer and with life-threatening diseases were affected during COVID. So not only people who were infected, but other very vulnerable groups had restricted access to clinical care and to medicine, or to cross-border health, or clinical trials entirely stopped. And these are some of the things that I would like to talk about. And besides my work with Youth Cancer Europe is also one of the founding members of the EU Health Coalition that's going to host a European summit for all disease areas, obviously, later on in November. And we're also working on the European Cancer Organization. All of these organizations have done so much, and we've gathered a lot of data and started to publish now to inform health systems and to be able to lobby for reorganization of healthcare delivery in preparation for any further new pandemics or the second wave.
Thank you so much, Katie. We can't wait to hear also your thoughts on how we can reorganize things, leverage this pandemic to improve things in the healthcare system and be prepared for potentially a second wave. I think this is a very important element. So I'm very excited that we're going to be having a great conversation. I will encourage everyone in the chat to send your questions. And because we're going to hear how things are not working and the struggles and the challenges, we're going to also hear how COVID is presenting, is helping us to learn new ways of doing things and how we could leverage those new ways to keep improving healthcare in our respective countries. So I'm going to start with Eleanor. If I can start with you. I have a question that obviously, if you could elaborate a little bit more how COVID has impacted the work for patient groups. Just a very short comment. This morning I was reading in the news that there is a new report that shows how COVID is affecting every aspect of cancer care, from diagnosis, treatment, clinical trials. And this is a very relevant report because it considers 157 cancer organizations in 56 countries, representing 350,000 patients. So I can see you nodding. I'm sure that you know about the report. But what are your thoughts?
Yeah, there's also another report that I saw this morning that said it was projecting that by the end of the year, how many not-for-profit organizations will actually not exist anymore because of what's happening with COVID. Of course, they're predicting something like 7% of all health-related not-for-profit groups may not exist by the end of this year because of COVID. So I want to talk a little bit about that. Our organization exists to help support the patient advocacy organizations in our membership and other organizations such as not-for-profits that do work in healthcare. And one of the things that we've been doing for the last 4 months to try to support all of them is we work in advocacy. We're hearing from all of them that they are undergoing a tremendous amount of stress because they are being called upon to do more and more work for their patient constituents who need help during the time of this pandemic. At the very same time that their resources are being pushed to the max, the usual venues that they would use to raise money, so for example, galas or fun run or walk or other kinds of activities like that, that would be where their revenue comes from, are of course being canceled because of the inability to hold in-person events. They are very quickly shifting to conducting virtual events, and they are learning more and more every day about how to create a successful virtual environment for these events. But what they're finding is that they can't possibly, in such a short period of time, make up the shortfall from what in-person events would have gotten for them. So what does that mean? It means that we're hearing in terms of the patient groups that their revenues could be dropping anywhere from 20% to 90% for this year because of the loss of those events. And that loss of revenue means that they are really having to think about how they can be a more efficient organization. They're having to lay off staff. They're having to furlough staff. They're having to close offices in various locations. And so all of those things put a tremendous amount of pressure on an organization that's already trying to be more and more responsive to larger requests and more requests because of what's happening with COVID. And our role as a patient advocacy organization that supports those organizations is to try to find ways to help them, to bring them together so that they can share information, lessons learned among them. So we bring the CEOs together regularly. We share information with them about, so for example, in the US government put together a loan program so that small businesses, and that included small patient advocacy organizations and large, up to certain size numbers, to be able to apply for loans to help them keep their staff on board and to help them keep doing the good work that they're doing. And we spread information about the availability of those loans to the patient community so that they would be able to apply for them. And we brought in guest speakers and consultants to help them be ready for doing that so that they can survive this ordeal and continue to provide the vital services that they provide to their constituents.
Wow, it is really impactful to hear some of the stats. For example, that 20 to 90% of the revenues of the patient associations could drop because obviously that will require a significant transformation in the way they operate moving forward.
It's putting so much pressure on them. I think one of the bright spots, if you could call it that, is that organizations are having a lot of self-reflection. How can I be a more efficient, stronger organization with fewer resources? What can we do differently to make ourselves resilient to be able to get through this time? And so they are looking at how can they right-size their organization? What are the right things that they can be doing to keep themselves sustainable? And so it is good, there are probably circumstances where maybe that self-reflection could have happened sooner, but didn't because you're busy doing other things. You have so many pressures on your organization, and this has forced you to think a little bit differently. It's unfortunate, though, that we recognize that many of these organizations aren't going to make it, and that's very, very serious for the patients that they serve.
Indeed, it is. And thank you, Eleanor. Talking about the patient's experience, we have Katie Jones. Would you like to share a little bit more about your own experience? It was a few years ago, but I think it's very relevant. And also, if you could reflect what will have happened if you had to go through the same experience these days with COVID, will be very useful.
Okay, for me, one of the things that I constantly want to bring up, and I have noticed there's been a significant change. not necessarily globally, but I know that when I had a talk in Tampa, they actually came up with a group that targeted patients for clinical trials, which was awesome because I live in Delaware, and in Delaware we have one big hospital. They went ahead and did everything they could as far as their protocols for me, and basically wrote me off. The good part about it was I had a doctor who knew that I had a lot of fight in me and wanted to continue to fight. And this doctor gave me the site clinicaltrials.gov and told me, I know you're a no quit guy. Spent a lot of time trying to get into these clinical trials. And I did. I put my diagnosis up there, and I basically created a macro that would allow me to create a canned letter that would send it to everybody. And I flooded their boxes trying to get some sort of treatment or a clinical trial when I wasn't offered anything else. Christiana Care, the Helen Graham Cancer Center here, is not a teaching facility, so they don't have access to a lot of clinical trials. They sent me over to University of Penn. They sent me over to Johns Hopkins in Baltimore, and I did everything to try to get into these clinical trials, and it was almost like trying to get into an exclusive club. I had no idea of how to do it. I flooded everyone. I heard absolutely nothing back. And I went a very unconventional way to get in there. When everyone else did not respond, I went to YouTube of all places and put my disease in there. And lo and behold, there was a doctor at Anderson, MD Anderson Cancer Center, who just put out a video about a trial that he was testing for people who've had multiple recurrences of Hodgkin's lymphoma, and was looking forward to getting patients there. So I said, you know, this is one guy that is saying everything that I need to hear right now. And his journey and my journey seem like they're parallel right now. I need to reach out to this guy. So I did, and I didn't expect to hear anything back from him at all, because like I said, I wrote a canned letter to hundreds of people and heard nothing back. This guy responded to me within 15 to 20 minutes himself. He called me. And I mentioned this in one of my talks before. I live in Delaware, and he was telling me about MD Anderson. To me, MD means Maryland, and I'm thinking that it's going to be at the most a 2-hour drive away. I'll make this. This is no problem. But when he told me he would like for me to come there, and I was like, look, I can be there in about 2 to 3 hours. He said, where are you coming from? I said, Newark, Delaware. And he's like, well, unless you got a heliport in your backyard, you're not going to get here in 2 hours. I said, where are you located? He said, well, I'm in Houston, Texas. And I, at the time, I just kind of looked over at my wife and I said, this is my only chance of survival. It's going to mean that we're going to have to stop paying some of these bills if I'm going to make this effort to try to live. And she said, well, we need to do whatever we can do to survive. And she gave me permission, and I flew out to Houston, Texas, and we did some treatments there. I went completely bankrupt doing that because every time I flew out to Houston, with the exception of the first time, it was on my dime. And when I got to Houston, the trial, I had to stay in Houston for 2 weeks out of every month. And I emptied out everything, savings, everything I had to, to basically make it. And when I couldn't come to Houston anymore and the cancer kept growing, I made so much of a connection with the people in Houston that the doctor in Houston said, look, I have a colleague who I went to school with who is the head of oncology at Memorial Sloan Kettering. Do you think you can go to New York instead of Houston? I was like, hell, I wish you would have said that a lot earlier. I'd have saved a lot of money and took the train. But long story short, I did some treatments at Memorial Sloan Kettering as well. The cancer kept coming back. I did some research on my own and found something that they were testing for leukemia. in that test, I noticed that it was going after a protein that I had seen in my charts. I'm one of this type of patients. I got to pick up everything. I got to read it, even if it's gibberish to me. I'm going to know all about myself before this is over with. And I've been in this body longer than most of the doctors that were practicing medicine. So I know what works with me, and I know I don't give up. I did go to New York. Tried some things there. They tried this treatment on me eventually that I begged them to try on me, and it worked. After 1 week of this treatment, they scanned me a week later, my cancer was down 65% after one dose. So as of right now, I love the idea that I'm given a forum where I can be that squeaky wheel for patients who would have normally not spoken up, because I was one of them until I had to pick up those charts, until I had to open my mouth. I lost my mother to cancer 2 years before I found out I was fighting it. And she told me on her deathbed that in my darkest hour, all I had to do was close my mouth and open my ears. The answer was going to come to me. And that's when I found that treatment that they were testing for leukemia, that ended up becoming my saving grace. And as of today, like I said, it's 2020. I haven't had a treatment in about 6 years, but I can pull my sleeve and still show you, I still have the chemo port in my arm to this very day. I'm going to go ahead and before I break and start losing, I'm going to go ahead and yield to whomever's next on the panel.
So thank you so much, Katie. Sorry for the loss of your mom, and sorry for everything that you had to go through, which it's insane. Thank you for sharing with us. It is at the same time inspiring to see your determination, your strong will, your ability to find a way. I wish it was much easier for every patient, and it had been much easier for you as well. And hopefully conversations like this one can help us find new ways. So thank you so much. I'm gonna ask Katie Rizvi also to tell us more about how the reality is changing in different countries. So you have an incredible opportunity to see the reality of many countries and how COVID is impacting differently in different countries.
Yes, but first of all, I don't think I can go on without saying something and reflecting on the story that Katie just shared with us. Such an incredible testimony to just health education and understanding your own disease and learning about it. And this is just so incredibly important that all of us and all our patients are as knowledgeable as possible, because you will pick up on things that nobody else will. And it's such an incredible testimony for so many different reasons. And one of them is also that I understand that a lot of our patients still don't even have their own health records. They don't even have access to their own medical records. They many times they don't read their own charts. They don't see their lab tests. They don't look at things. And how important it was for you, Katie, in actually finding a clinical trial and finding a therapy that actually ended up working for you, and how important it is for all the cancer survivors who have been told that they have overcome cancer, they have completed their cancer therapies, and now they are long-term survivors, and they should be looking out for some late effects. But a systematic screening is not done. It's hardly done in any country that I know of. Even long-term follow-up is just a term that we are using in the last 4 or 5 years, really. In Europe, The largest cohort that we have is 80,000 pediatric cancer survivors, pediatric cancer patients in a tumor register for long-term effects study that is done by Banque, where I'm also working. And we also know that many of these late follow-up screenings and long-term follow-up clinic visits have been completely put on the back burner, even in countries where follow-up clinics exist. And a lot of our cancer survivors actually told us about a feeling of abandonment by the system during this time, during the COVID era, because they were just simply not a priority. Cancer patients were not a priority. And as we know, and as we heard, and as we've seen testimonials, that clinical trials have stopped, they don't have access to cross-border therapies, their appointments, chemotherapy appointments, radiotherapy appointments were delayed. And we have actually now data coming in about up to 50% of all our patients, our active patients, have been affected by COVID in this way. But long-term cancer survivors feel a completely different dynamic of it. Maybe they don't have a radiotherapy appointment delayed, but they have other feelings of the system not caring for them. They are not being called in for follow-up, and many of them have heightened levels of anxiety and worry that they are facing right now in this era. So actually, I wanted to say that we will have some of this work published and talked about in the next European Cancer Organizations Summit, which I will look for a link and I will send to everyone. This is which is going to happen in October. So we can actually look at how cancer care has been affected by COVID. And we will also put together some considerations for reorganizing care. So currently, the Commission's comments and proposals for change only relate to, in this document that was just published, is only talking about hospital reorganization and care reorganization to handle the pandemic or handle a second wave. What we still don't have yet is recommendations for reorganizing care for vulnerable populations. And this is something that we really want to talk about and speak to. So on the 20th of July, so next week, actually, I will have a meeting with one of the directors of the European Commission, DG Santa, along with the chairman of Youth Cancer Europe. And there are also some other forums where we are currently working on very strong recommendations. So for patients that are interested in this, whether cancer or other disease areas, they will be able to participate in the dialogue that the European Health Coalition is hosting very specifically in gathering policy recommendations on reorganizing access to care and reorganizing safe clinical care access for vulnerable populations for a second wave of the pandemic. And this is as specific as you can get. And I think it's really important for all of our patients who are on this call right now to know that your voice matters, that you are invited to contribute to this dialogue, and that there are these very specific forums that are working on recommendations and policy objectives that I am very, very, very sure, 100% sure, will inform the future of Europe.
Thank you so much, Katie, and looking forward to hearing how in Europe cancer care can be reorganized to also protect the more vulnerable population. So thank you. I'm going to shift now to Lily Cannon. I have a question for her, and then we're going to open up for the many questions that are coming up in our chat. So please keep sending your questions. We have plenty of time, and I'm going to switch to the chat very soon. But before that, for Lily, I have a question for you regarding thalassemia patients. Some of them require frequent hospital care. So how has COVID impacted that need and their ability to seek for this frequent hospital care, and what patients are doing about this?
Yeah, thank you, Esther. It feels very daunting to follow Katie and Katie's statements coming from a benign hematological disease area where our patients are not in such an urgent need of medical care. However, as you say, they do require lifelong visits to the hospital, especially most of our patients require to go in at least 2 times a month for their blood transfusions. And obviously this was impossible with COVID. So at the beginning of the pandemic, what was required from us as the international federation representing these patients is a head of governments, a head of hospitals, a head of health authorities, to come up with some guidelines, some pathways to help the hospitals put in place protective measures for our patients. So we developed a specific care pathway that would enable the limitation of patients to actually have to go into hospital if possible, or if they could receive home care in any way, shape or form. In addition to receiving medication at home, rather than having to go to hospital dispensaries and pharmacies. And the most important issue that we found to be the most valuable is the additional triage that we recommended ahead of their entering the hospital. So to check for their hemoglobin and other symptoms, to make sure that they weren't, if they were infected with COVID, that they weren't passing this on to other patients or the hospital staff. Luckily, our reports from across the world have been that there are very few patients with thalassemia that have been infected with COVID, so that's a good thing. And those that have been infected mostly have had mild symptoms. What our major concern is at the moment is that as the pandemic is increasing in the developing world where most of our patients live, that their access to safe blood and blood screening practices is becoming limited. So they're now asked not to go into the hospital at all unless their hemoglobin is under 6, which is basically an emergency, since our international guidelines call for 9 and over pre-transfusion hemoglobin levels. And that there's a severe underreporting of these chronic illnesses with COVID. So we are in the unfortunate position of assuming that many of our patients are dying at home and not receiving appropriate medical care. As the International Federation, we have a responsibility towards the entire community to put out as much information as possible, both for patients and for doctors. But I'm sure everyone can relate to the unknown aspects of the coronavirus that erupted so, I'm trying to think of the right word, explosively and suddenly came and hit all our doors. So we created a help desk in order to help our patients and doctors across the world with any of their queries. We have an on-call scientific advisory committee. And while all of this is going on, obviously, all of our access to innovative therapies and clinical trials have been halted as well. So there is a major setback And for various reasons, either in terms of research or in terms of accessibility to basic care like safe blood, our federation believes that we are facing setbacks of at least 20 years. So we're going 20 years into the past in some of the developing countries.
Which is also a scary stat. All the work done over the last 20 years, great work, we cannot allow that this is gone. So I'm happy that we're having these very difficult conversations to help move the needle. Thank you, Lily. We have several questions coming up through the chat. There is one question that it's addressed to anyone who can take, who wants to address it in the panel. That is about racial disparities in affecting also healthcare access to patients. That has been also more acute during COVID. It may be potentially more present in the US than in other countries, but I don't want to make that statement because I think in other countries we may have also some issues. Maybe let's start with the US. Maybe Eleanor, I can see you active, so please go ahead.
Yeah, so I think it's a big wake-up call for us all. We always knew that there were disparities, and they've been recognized in many ways. Research has recognized these disparities. But now with COVID, it has become so much more obvious, so much more kind of an open wound that we have to take care of, and it's much more recognized now. And I think we're talking about all kinds of disparities. So while we've had some racial unrest and protests going on in the country, it's really disparities across the board. I think we're feeling that this is driven by what we've seen happening because of race, but we're also recognizing that these are very across the board kinds of disparities that really have to be addressed in order for us to have health equity. And so one of the things that we work on is always advocacy work to be sure that we have equity in the way that healthcare is provided, and that there's accessibility, access to healthcare for all, fair access, equal access to all. I think one of the things that's happened in the last few months in this country is that we've realized that we cannot solve healthcare disparity issues until we solve across the board issues, not just in healthcare, but in our society, in law, in so many other places in our society. We can't expect the healthcare system to fix and address health disparities when the disparities are elsewhere, and that we have to think about that as a nation and in our society before we can put all of the burden on the healthcare system to fix health disparities. These two things have to go hand in hand. And so I think that these are the kinds of things that you're going to see many more discussions about, much more effort towards where the research is going to go, discussion about in the policy sphere, where do the dollars go in order to address these kinds of issues. And it's going to be a very serious conversation that this country has to have.
I think you bring an extraordinary point, which is the root cause. The health disparities are driven by disparities in our society.
In other places, in many other places.
And we have to fix that. We cannot tolerate discrimination or
of any kind. Yes. And so, I think if we can begin with race, because that's the one that is in front of us and is really something that COVID has obviously put in front of us to address. We know we have to address all of them. We have to start somewhere.
Excellent point, Eleanor. I'm thinking, is there anyone in the panel that would like to address other disparities that we are also seeing in the US, outside of the US, not necessarily related to racial discrimination, but any other disparities also affecting patients?
Well, absolutely. I would speak about economic disparities. And you will have this in the States as well. And also, I think, insurance challenges. In Europe, just geography and it is, you know, just it is a determinant on your survival rate. And that's a horrible thing. It feels like we are in the Middle Ages, where it really depended where you were born, whether you were gonna live or die. But it's just so dark and so grim, but it's still the case. Less affluent countries are not able to provide certain medicines. Medicine shortages were already a problem. Negotiating also with big pharma was also a problem. Market access authorizations, HTA assessments, problem, one after the other. I mean, even before the pandemic, we were just going around in a political circle just about HTA assessments and harmonization across Europe. And now with the pandemic, all of that has been on the back burner, but now we see even more that even medicines that were accessible now, because of the pandemic, there are further shortages. And these are the ripple effects of such a global pandemic that are not only affecting people that are infected, but affect all other groups, especially vulnerable groups. So people who depend on medicines, medication, especially on hospital administered medication, or a medication that requires hospital admission, not only in a daycare setting. Those patients have been really suffering. But yes, economic disparities will be a predetermining factor on how well you survive, and also on your quality of life afterwards. People who have access to the most basic medical therapeutic interventions, such as amputation, will have a different quality of life than people with limb-saving surgery and limb-saving intervention. And we see this, and for example, a very simple example, we were just talking about one of our good friends in Youth Cancer Europe, who was born in Romania, was not able to access certain therapies, so out of desperation hopped over the border, because literally she was in a border town, hopped over the border to Hungary, and she was able to access a different kind of therapy. But for that, she needed a European health insurance, which was easy. She was able to pay for, but she still had to co-pay. Now, co-payment for somebody who's earning in Hungary or earning in Germany or in Switzerland will have a different strain on them and on their families than having to live on a salary from Romania or from another poorer European country. So yes, economic disparities will have a direct effect on the kind of care that you will be able to access. And it's a shameful thing to say in this age. And it's a shameful thing to say for someone in the European Union, the utopia of what it was promised to be.
Thank you, Katie. And actually, this is unfortunately a clear reality we need to face. And I can only see finding solutions with every part of the healthcare system working together to make that happen. To the other KT, it's a very interesting dynamic. Katie to Katie, but Katie Jones. Related to that economic struggle, there is also an interesting question in the chat that people would like to know how you manage when you went bankrupt and you had to face very serious economic challenges. How did you manage? If you don't mind sharing.
It's strange because it doesn't seem as though, I mean, it impacted us, of course. We just had to really buckle down and reprioritize. We're doing the same thing now. I actually had to return to work full time. I do customer support for a cable company, along with doing the photography and the speaking and things like that. I wear many hats. That's bald head of mine. But my wife, who's a professional chef, actually ended up getting furloughed for a while and then ended up losing her job altogether because things won't be the same. They don't have the employees coming in anymore to the facility where she was cooking. So right now she's currently looking for a job. We've basically have been managing. I mean, I don't know, I guess by the grace of God and just retooling priorities and just cutting corners as much as we can, we're making it. It's not an easy task. I mean, it's just something that sometimes you gotta rob Peter to pay Paul.
Thank you, Katie. And I'm curious, is there any learning that you had personally when you had to face such a difficult situation, not only because of your health, but also because of the financial situation? Any learning you like to share with us?
Well, I mentioned it before about just kind of retooling and just changing priorities. Not just financially, but even spiritually and physically. Sometimes you had to focus on different things. Like for me, I didn't have a chance to grieve my mother's death because I ended up in a battle myself. And at one point in time, I had a spiritual moment where I actually questioned my own survival. I woke up one day and was like, God, why am I still here? My mother was a much better person than I am. But when my foot was stepped on and I had to scream and I had to use that voice, and I was able to see, and I mentioned it in chat, the other people being able to survive because I was able to open my mouth, not just myself, to have a group of people from Russia come over to interview me to tell me that I am a lifesaver, that I've actually changed their way of thinking when it came to treating some of these diseases. That had more of an impact on me than my own personal survival. So I've been an open book. I have fought for many of people who have never actually heard my actual voice, who've only known me through like social media or have found me because of a New York Times article, or they've seen or heard something about me before. I've become that squeaky wheel, so to speak. And again, I mean, I just want to show gratitude because you guys have not only been a intricate part of this, you continue to allow me to be a part of it. And I look forward to being able to save lives, and that's my goal.
Katie, your words are very moving, and your personal growth, spiritual growth, incredibly inspiring. Thank you for sharing. You found inner strength in the darkest times of your experience, and I can only tell you that that's extremely inspiring. And actually, I was reflecting as you were speaking that there is a Chinese character that I'm sure that many of you are familiar with, that is the same character that has two meanings, which is crisis and opportunity, and it comes together. And I'm one of the biggest learnings I had for listening to stories like yours, and also personal learnings, is in the most difficult times, this is when sometimes we find that inner strength to retool, reinvent, redefine ourselves and what's around us. And I'm thinking that for the next few minutes, I would like to invite the panel to think about that reinvention. What can be done? Because many things are not working and COVID is just creating a situation maybe more severe. But I know the panelists have also a very positive spirit. You are exemplary of that very strong will and willingness to change things and fight for what is right. And that's what is so inspiring. So would you like to share your thoughts on how we can also change things, reinvent? Where are you learning already that could help us be in a better spot?
Well, I'll jump in. So KT, thank you for sharing so much, because it takes a lot of strength to be able to share the personal things that you share with us, and we really appreciate that. And I think you're an example of the kind of resilience that we see with patients who really take control of their own situation, and that's the strength that we see across the board. It's so powerful. Thank you for that. But you know, KT's story is happening more and more across the United States right now, and I'm sure throughout the world. People who have lost their jobs are losing their insurance. And so you lose your health insurance, and it puts you in an even worse situation than just having an illness itself, or just having the illness present in our country. We have to figure out how we keep people with access to care and provide that support for them and the insurance that they need, even though they have lost their jobs. And that's one of the things that, at least in our organization, that we work very hard for and that we advocate for, that kind of support and access that individuals like KT's family will need in this worst time. Because, you know, we just have, in the last 4 to 5 months in the US, 40 million people who have reported that they are now out of work. And that means that if they were supporting their family, it means they and their family members are at high risk of having no coverage for their health care. That's a terrible situation, and it's a growing number. And so we have to work hard to be sure that we continue to provide the access to care that they are going to need to help them get through this time.
Thank you so much, Eleanor. So I'm glad to hear that there are organizations that are supporting patients that lost their insurance and coverage, and therefore access to healthcare. I'm also happy to see that they are across different industries, and also in our own industry, there are companies that are also supporting those patients. In particular, Bristol Myers Squibb is also providing that support. And I think it is in these moments where we all need to get together and do our part. So thank you so much for sharing. I can see Katie Rizvi also willing to contribute. Please go ahead.
Yes. I think actually it was coined in one of the publications as ordeal to opportunity, because COVID also shed the light on some of the ways that we can cope with things more efficiently. And I think Lily was telling us about a safer patient pathway that you actually have shared with your member organizations for them to lobby for on a national level. And I think we will see more and more initiatives like that, because the pandemic has shown us that there is a way to reorganize care delivery with social distancing in mind, with safe patient access, and hospital reorganization is already on the European Commission's radar and agenda. And I think this is the moment for us to speak up locally in our respective states or in our respective countries, and to see how this can be influenced. But I also know that lobbying for things and advocating for things does take time. This is why you need to be part of European initiatives, international initiatives, policy networks, so that you can advocate together. But there are things that are already being done by patient organizations for their own communities. that are services, changed services. A lot of organizations have pivoted. I know Eleanor was talking about this in the beginning. They reinvent themselves. And a couple of these very concrete examples are that, for example, we piloted it first in Romania. Now we offer online psychotherapy, psychological consultation, but also behavioral therapy, psychotherapy. All of these sessions are right now online on a massive platform with more than 300 specialists that are dedicated to work on that platform. And we contracted 20 of those to provide for our own community. And we are able to do this, and through emergency funds, we just pay for these consultations because we know how important this is. At the same time, we also have a more sophisticated chatbot in the works for a pediatric oncology population, which is really important for all of those children that we work with. We work with about 2,000 children annually in the clinical setting. And these children are even more isolated right now. There are no visiting hours. Their mommies can't even just pop out for a soda or to buy their favorite fruit or a favorite snack. They are really isolated. And some of the work that we were able to do until now in group therapy settings, through play therapy and many other interventions, we are now providing online through a chatbot and AI, but also by directly pushing therapeutic activities, relaxation activities, and meditation techniques to the children and their families. So there's a lot of services that we are now able to put in the digital space. The question remains though, that if we will have to make a more permanent strategy for many of these services, not only the complementary services, but also first line medical care services, and move them into a virtual space through virtual consultations and telemedicine. Will legislation support us? And in some of the countries that we've mapped, virtual clinics are not, and virtual consultations are not reimbursed. And so we already see some very, very small policy areas where we can act immediately right now to make sure that some of these services will be reimbursed, because we can actually advocate for more virtual clinics being set up, literally not from one day to the next, but I think you get my drift, very quickly, just for handling some of our very vulnerable population who are not seen in the regular clinical centers, but who could be consulted by a specialist in a virtual space. And we just need to make sure that the regulatory framework changes a little bit, not a lot, but just at least a little bit, to allow for some of these services. And these will be some of the immediate good outcomes of COVID, that we were forced into making some of these services more efficient and more accessible. Like somebody was also writing, just give a phone to each patient so they can be in touch. Yes, there's already a lot, I've seen this in the chat, like there is a lot of, there are a lot of peer support and peer matching apps. I know that GREAT has one, Youth Cancer Europe also has one, but we're not utilizing these as much as we could. And I think this global emergency is forcing us to be smarter, forcing us to work more efficiently, and forcing us just to tie those loose ends so that we can make these systematic provisions, not just ad hoc, interesting services, but be actual part of the care delivery and available for every patient.
Yeah, I think a lot of what Kate said is also true for the US, because, you know, we had such a small amount of use of telemedicine prior, and the explosion that happened, has happened during the pandemic. It relied on there being some changes made in legislation and in payment policies in order to have those visits paid for. And now that they're being paid for, of course, they're being used to dramatically higher rates. What we can't have is for policymakers and the people who make the decisions about insurance coverage and how payment is made. We can't have them say, oh, okay, well, you know, we can go back to the way that it was before. No, we've made tremendous progress. Let's figure out how to make some of these changes permanent and figure out a way to get them paid for in appropriate ways, and validate that they actually are improving outcomes as we firmly believe that they are.
Thank you very much, Eleanor and Katie. We have Lily that she also wants to contribute to the conversation. Please go ahead.
Yeah, it was really interesting to hear both Katie and Eleanor's perspectives, and I completely agree. Coming from a more international scene, however, I'm also vigilant of the fact that we're talking about Europe and America, that there is the infrastructure in place to help with this swift move towards telemedicine and virtual visits, etc. This isn't possible in many parts of the world, not only due to infrastructure, but also to the nature of their health systems, which as TIFF, we find this opportunity with COVID to push even more the UN Sustainable Development Goals for achieving universal health coverage, especially in countries in Asia, where a lot of out-of-pocket expenses are incurred by patients and their families. And during the pandemic, even in these really dire circumstances, a lot of people have lost their jobs, as we've seen. There's financial insecurities. We recently received an email from a mother of two thalassemia patients in Morocco, saying that even in the best of times, based on her monthly salary, she had to choose which child would be transfused. So one child would be transfused and one not. And this is even more difficult now because both she and her husband have lost their jobs. So parents and patients are being put in incredibly difficult positions. And I think we all have a responsibility, being in the healthcare sector, to push for more universal health coverage, more infrastructures to be put in place, and definitely a reorganization of the delivery of care, if that will make it easier to for it to be more accessible to more patients.
Thank you, Lily. Any reaction to that comment, especially the ones when you need to choose between one? I cannot imagine. I have twins, so twin girls, so I can tell you that comment really touched me deeply. Any reaction? Anything that can be done that is in our hands to change these things?
Well, I think from our perspective, you know, we're a big advocacy organization, so we spend a lot of time advocating for different kinds of healthcare legislation and policies for implementation at the government level. So, as I said in the chat, strength in numbers. You know, as we're all working together and banding together, all of our organizations can work together to try to achieve these things, to be sure that we have the right kinds of policies in place, especially when it comes to making insurance available, making sure that insurance has the right kind of coverage and access, ability for people to access, and that the out-of-pocket costs are as reasonable as possible, so that no one gets left behind. And you know, one of the things that's been very important for us this past year is thinking about health equity, but also thinking, you know, when it comes to COVID treatment, making sure that it's accessible to everyone at little to no cost. And the day is going to come when we're going to have a vaccine, and we have to work really hard to make sure that vaccine is available to everyone.
I couldn't agree more. We have just a few more minutes left before we close. And I was just thinking, number one, if there is any comment from the panel that you like to make before I maybe pose my last question. No? So I guess my last question, trying to also leave the conversation on a positive side. Is there any example of organization or country, any part of the world where you think they're managing the healthcare disparities better than anyone, managing COVID situation better than anyone? I hope we can find one to share with the audience. Any, from our panelists, any bright spots left to share? I know we have shared some. I really appreciate the effort. Anything else you'd like to share before we close the conversation? Katie?
I think I would just say, I don't think any of us would say that any of the countries performed brilliantly lately. And also we're working with very vulnerable patients, and you will find we have, so if we look at cancer, we look in our communities, and we have some members from the Northern European countries where cancer cure rates are the highest in Europe, but they suffer some of the most compelling stories of the need for mental health support and mental health consultations, and the deepest stories of desperation come from that region. So I honestly can tell by looking at what I can see from our pan-European organization that literally there is no one country that has got everything right. I think there are best practices that from everywhere that we have the opportunity and the obligation to share. And this is the best that can be done at European level as well. So when I was reading the European Commission's very weak recommendations and quick note on handling and how and preparing for the next wave, the second wave of the pandemic, there are comments like sharing best practices of testing and care, especially for medically vulnerable groups and settings, from July to September. That's their timeline, So nobody is getting it really, really right. But if there is only one thing that I can say on this panel before leaving is to make your voice heard. I mean, there are so many bright people and so many very strong advocates even on this call. I'm just reading the chat and I'm recognizing so many people. Be there in those working groups, go to those conferences. If you cannot participate, right now we're advocating for virtual participation everywhere. You will not even have to pay. There are many times a free admission for patient advocates. Just apply, participate, have your voice be heard. Let Europe and the continent hear our voices as patients. I don't think we are heard enough just yet. I think patient advocacy is still walking in baby shoes, and I think it's very important for everyone to appreciate that no matter how small you are, no matter how insignificant you might feel, your voice really does matter. Because if you would attend one of these meetings and all of these consultations, either with the EMA, at the European Parliament, with the European Commission, literally the people who sit there are not always the most knowledgeable. They are literally just you and I, students, people with jobs, and your voice could be sometimes 100 times smarter than some of the other people's voices who are sitting there. So put yourself out there, let your story be heard, contribute to the conversation, and let's build a better world. And let's not lose momentum, because we've learned so much. We want to reshape healthcare. Let's reshape it according to what we believe it should be like.
Wow, Katie, super. I think you just remind us that each voice counts. There is no small voice. And in history, we have seen so many times that when we all unite our voices and we share our strong voices, we change things and good things happen. So I think Lily wanted to say a final comment. I want to make sure we have covered the wheel of the entire panel, and then we're going to finish and give back the word to Dave.
Yeah, it just reminded me of the mouse that roared, bringing the patient perspective and the patient voice to any discussion on healthcare policy, no matter how small or big it is super important. It can't be replaced with anybody. And no matter how well doctors believe that they know a disease, it's different to live with it and to be in that body. I mean, even myself, I'm not a patient myself, and I can't advocate as much as a patient would. So, and I'm a strong believer in parent voices as well. I think that they have a unique perspective to bring to the table. So if there's anything that I consider a bright spot in this pandemic is that with everything going virtual and all these consultations and these meetings going virtual, I think as patient advocates, whether we're patients or parents or just advocates, it gives us the opportunity to be in a lot more places at the same time. I mean, personally, I was trying to attend maybe one a month, traveling, and now I can do one a week. So it's an exponential amount of knowledge and perspective that we are sharing between ourselves. And just as a final comment on which country is doing it best in dealing with the pandemic, I'm going to agree that none of them are actually doing their best. There are small pockets of knowledge that each one can bring to the table, but it really needs to come all together. There's a lot of wishy-washiness out there, but I think we can all learn from each other and be prepared for perhaps the next wave or the next pandemic.
Thank you so much. Just to close up, every voice is a powerful voice, and with the power of internet, we can get patients right, really right. Thank you. Back to you, Dave.
Oh my God, I don't know where to pick up from. What an inspiring ending and incredible conversation. If I can ask everyone who's in the audience with us right now, when you think of the word advocate, what one word comes to mind? Please type in what advocate or advocating means to you. And I want to see what word everybody, oh my gosh. I hope everybody on our panel, you feel those words, because you are heroes, and empowerment, and everyone in our audience, whether you're full-time as an advocate or advocating for yourself as an individual or in industry as an advocate, whatever role you play, champion, future, warrior, these are what describes our work together. Wow, I'll try to package it up. Ester, what a human, really amazing conversation. And to hear the passion in your work and what everybody's doing and the conversations it inspired. The one word that was in my mind this whole session is courage. And KT, I think of when I hear your story and the courage it took to never give up. And each time a door was closed, you found a new door. That is advocacy, and you are the embodiment of what being an advocate means. And hearing you say those things, they connected with things inside me that were trapped before I knew how to find a voice. You know, and one of the most amazing miracles in life is finding our voice so that we can connect with others and make positive change. Jess, who is on our panel screen right now, I know you can't see her if you're watching at home, but KT, I don't know if you could see Jess's face when you were telling your story. She last week told her story, and Jess and I work together every single day. And she shared things about what missing screenings and what preventative medicine means in her life. And I know Jess among the best, and I learned things last week from her voice that I didn't know. And so this panel to me is the best of that, finding our voice and using our voice. Just one other thing I'll share. I heard, Esther, from your comments and everybody's, is that all of this is connected, and we can't fix healthcare as an isolated thing. We are talking about society and cultural and humanity. And I adore how everyone connected that we are talking about humanity in these issues and how much they mean to us and individuals. These things involve, KT, you talked about survivor guilt and patient empowerment, and these are really complex human issues. And to have this time together is real courage. And I want to thank everybody for leaning into these conversations. I know that our internal team, when we set this up, Kathy and Jody and everybody at Bristol Myers Squibb and Evoke Kind and all of the advocates we talked to, we really leaned in to some tough topics. And this moment isn't about having all the answers. It is about the courage to talk about the tough things that need to be talked about. And it's just humbling to be a part of that. Next week's session, which is our 10th session, is patient voice. And Katie, I can't think of a more inspiring way to describe it than what you just left us with. So next week in our patient voice conversation, we're going to have one of the leaders from UPADI, which trains patients to have their voice. And so if you want to learn to be trained, learn what it means to have a voice in healthcare, please join us. Please spread the word. We'd love for everyone to know so they can learn from UPADI. Oriana, I see, is in the audience with us today. She not only is going through that training, but she's early in finding her voice, and what a powerful patient voice Oriana brings. Kathleen, who will be on our panel, has spent the last 30 years advocating for lupus and improvements in care for lupus. She's testified in front of the FDA dozens of times, and you'll get to hear from a real expert in patient voice. Begonia is part of elevating rare diseases around the world, and so she'll be on the panel. And all of this next week will be led by the Chief Medical Officer for Bristol Myers Squibb, who is passionate about how we include our voice at all stages of drug development. And so what an amazing session next week. This session is just truly humbling. All of these are recorded, so please go back anytime. Let your friends know to come back, and anybody that might need or benefit from these sessions. And then on August 6th, we will have a resource day and virtual fair. So more information coming from that. There'll be a morning time, 7 a.m. East time, so that Katie and everybody in Europe can be a part of it at a more reasonable time during your day, and those in Australia as well. And then there'll be an afternoon time that will be for East Coast and Pacific Coast, and working that way in the geography. I'm too excited. I just need to stop and wrap it up. My great admiration and gratitude for everybody. Thank you so much, and we will see you all again very soon. Cheers.